All right. Well, thank you so much. Really appreciate everyone joining in tonight to the webinar number 8 for the Drive to Deprescribe initiative. This is, I think we're crossing a 1-year mark now with this webinar. So this is exciting that we have continued and just done some amazing presentations. That we have seen some great work happening. So we continue that tradition today with a very important topic. And we heard many of you actually talk about the need for this topic. So we are very excited to bring to you a very good educational session on the optimizing the use of anti-epileptics and anti-seizure medications. I don't know about you guys, but for me, this has always have been an area of a little bit of a heartburn, where I kind of try to act like a confident expert in the facilities, trying to address this issue of anti-epileptic, anti-seizure medications. But I truly felt the need for more learning on this. And again, I won't take too much blame for that. I think literature just has not been ripe around this area that much. So we actually were very excited that we have the best possible expert to talk about this topic today in regards to how can we optimize and then more importantly, deprescribe these medications, what is safe, what is not safe, and just give you some best practices and some good pearls in your practice in your day. With that, I'm going to introduce Dr. Sam Turman. He's a neurologist who actually specializes in caring for patients with seizures and epilepsy. He did his MD and his MS in clinical research in Michigan in 2014, and specifically did expertise in statistics and epidemiology. And then he completed his neurology residency in University of Michigan in 2018, and then pursued further subspecialty training during doing epilepsy fellowship at the University of Michigan. So yeah, I could go on and on, but he also has a healthcare research fellowship at University of Michigan Institute for Healthcare Policy and Innovation. So very excited to have him on board today as our faculty. And Sam, the stage is yours, and let's learn some from you. Thank you so much for doing this.
Well, thank you. Well, I'll admit I am a board certified epileptologist, but the topic still causes me some heartburn, so I can't guarantee.
Good to know. I feel better already.
So thank you. I'm gonna make sure my slides are working. So participation is encouraged. Please use the chat function if you have any questions. The chat is being monitored, even if my eyes are off the chat. Another one of our planning members are looking at it and can ask questions in real time or after the session at the end. So the topic is optimizing use of anti-epileptics and anti-seizure medications. Much of my clinical time involves epilepsy clinic and EEG monitoring. So that's the bulk of my clinical activities, is thinking about seizures and epilepsy and seizure mimics. Of no disclosures. There are 3 objectives to this talk today. One is list some indications for anti-seizure medications within relevant settings, determine when anti-seizure medications for epilepsy are potentially eligible for deprescribing. And again, it's murky, but I'll give you some of my thoughts on the topic, and design an anti-seizure medication deprescribing tapering plan. It's a short session, can't possibly cover everything, but I'll give you a flavor at least. So the first question is, what's in a name? There's a lot of confusion about terms involving seizures. Seizure semiology, the terms have just changed over the last decades, and probably so too with anti-seizure medications. So I have a Venn diagram here just to make the point that there's anti-seizure medications, anti-epileptic medications, anti-convulsant medications, and is it a medication or is it a drug? Well, you can have seizures without epilepsy, for example, a provoked seizure. You can have convulsions without epilepsy, for example, convulsive syncope, or even psychogenic non-epileptic seizures. And so seizures are not epilepsy or not convulsions, and not all anti-seizure medications are used for seizures. So it's an extremely confusing pool of terminology. I'll simplify this here, and I'll just use anti-seizure medications, but referring to essentially all these things. What type of medications are we talking about today? There are 30 plus anti-seizure medications on the market, and they're growing. This is a graph from Medicare. I looked at people enrolled in A, B, and D in the span of a number of years, and gabapentin is the 50% gorilla in the room here, and it's been increasing. The broad trend is there are newer generation anti-seizure medications that are increasingly coming online. Levetiracetam is another very common one that I deal with, and that your patients may be on. And some other anti-seizure medications like phenytoin are perhaps decreasing. So this is all comers, everyone with Medicare, not restricted to seizures, just to give you an idea of some of the most common medications that we're talking about here. How common are they? Well, in that study, about 1 in 5 Medicare beneficiaries are on one of these drugs. Again, gabapentin is being one of the major players, but many others are also common. And 11% of nursing home residents are on anti-seizure medications. This is probably an outdated number, and I suspect that the true number these days is actually quite a bit higher. But the point is that they're extremely diverse and pretty common in practice. So I mentioned seizures is not the same thing as epilepsy, is not the same thing as convulsions, as there are many indications. So just to list some of those indications here. So now you're sorry you asked, ... because they're indication after indication after indication. They're on-label indications, off-label indications, and gabapentin is used for basically everything in terms of neuropsychiatric symptoms. So alcohol use disorder, anxiety, bipolar, epilepsy, fibromyalgia, migraine. There's some weird oddities that we as neurologists like to think of, paroxysmal dyskinesias. But neuropathic pain is a big one. Pregabalin and gabapentin can be used for restless leg syndrome. Essential tremor is something that we see as neurologists, et cetera. The list goes on. So the question is that all these medications have their good and their bad. It's kind of a Dr. Jekyll, Mr. Hyde. You know the possible benefits and also the possible dangers of central nervous system polypharmacy. So we always must weigh the good and the bad. And I know this group may be very attuned to algorithms. Clinical algorithms are very important to help us weigh the good and the bad. Is there an indication? When is there not an indication? When are there tailoring variables that may help us understand which patient, which medication, and when? So I must apologize. There's no single ASM deprescribing algorithm that I think I can faithfully report to you. Deprescribing.org does report a number of algorithms, for example, benzodiazepines and sleep aids, and there may be some others for proton pump inhibitors and other topics of research. Anti-seizure medications is a real place where a guideline would be quite useful, but I don't think we're there yet in the literature. And the reasons are that every person is different. There are perils of diagnosis, either false positives or false negatives. You as long-term care specialists may inherit patients and you don't always know why people come in on all these medications. Even if you know the diagnosis for certain, the risks and benefits can be sometimes opaque, not completely transparent. And again, you only have so much time to actually counsel people and thinking through a lot of different things. But even though there's no clear black and white algorithm, we do have data. And I can't possibly do justice to all the data in this brief session. I'm going to give you a few highlights. So the bad, specifically in terms of deprescribing for patients with epilepsy, and I'll focus that epilepsy. As I mentioned, there are a lot of indications out there, but that's most of my clinical work. And I think probably seizures and epilepsy give you the most heartburn in terms of when thinking about deprescribing anti-seizure medication. So I'll focus on that for a number of slides. So the bad is if you have someone with seizures and epilepsy, if you pull away their seizure medications, on average, you likely do increase the risk of having more seizures. And the question is, well, how much? And so there is a randomized controlled trial, and I'm showing the Kaplan-Meier curves here, for continuing versus discontinuing. These are people who are 2 years or more seizure-free with epilepsy across a whole bunch of centers in the United Kingdom. It's old data, but it's basically the best that we have. And the number that sticks in my mind is pretty much, on average, 20% versus 40% have at least one seizure if you continue their medicines versus if you don't, among patients with epilepsy who've been seizure-free for 2 years. These are adults and children, very heterogeneous population, but to simplify it, these are the average curves. So that's the bad. The good is that other studies have shown a slight reduction in side effects from deprescribing anti-seizure medications in this population. Seizure medicines have all kinds of side effects: mood side effects, liver, blood, cognitive, falls, the list goes on. And that bullet point specifically refers to executive function and some other neuropsychological tests. Granted, that was predominantly in some of the older generation drugs, such as carbamazepine and phenytoin. And so the newer generation drugs may have differences in side effects, but conceptually, the bad is more seizures, but the good is fewer side effects, potentially. Neutral In another randomized control trial, there was little difference in quality of life in people who did versus didn't deprescribe their anti-seizure medication. And there was nobody who died or went to status epilepticus in these trials attributable to deprescribing. In fact, the only two people who died, the investigators deemed of a seizure in this trial were two people in the continuation group. So, chance is chance, and you're not going to conclude that deprescribing reduces mortality, or that deprescribing reduces mortality, but overall, this is people with well-controlled epilepsy, all comers, is in general a low-risk population. Serious consequences to deprescribing were not identified in these studies, even though seizure risk was increased. Although there's no single guideline, no clear algorithm, there are some guidelines, and there have been 3 guidelines basically published on the topic. One was in the 90s, that was the original, and then 2013, and then one came out just last year. And there's been some evolution. So basically the numbers that you might be familiar with is that people who are at least 2 years seizure-free may be eligible for deprescribing. So if there's one blunt caveman type of recommendation that I can give to you, that is what's taught to neurology residents and has been taught to neurology residents for decades as a result of this guideline in the 90s. People who are at least 2 years seizure-free may be eligible for deprescribing after a risk and benefit discussion. They quoted a mean relapse of approximately 30 to 40%. I showed you the Kaplan-Meier curve, and I quoted 40% from that randomized trial. And they identified people with the greatest chance for a successful drug withdrawal are people with low-risk features, people with a normal EEG, people with a normal exam, people who have been seizure-free for longer. Basically, these guidelines were reiterated in 2013 and another set of guidelines. After at least 2 years seizure-free, shorter periods should be discouraged because of higher risk. I am actively pursuing research in this topic. I ask a large number of neurologists in a survey that's under review, and this is a work in progress. How long do you wait? I ask people a lot of things, but this is one of the simplest. How long do you wait in terms of seizure freedom before you would consider stopping seizure medications? And I have children and adults. I also stratify by convulsive versus non-convulsive seizures. But basically the answer is people said they follow about the 2-year guideline. So for children, pretty right on the money, they're 2 years. Adults, there was some greater variability. The dots represent the median, the center of the distribution. In the US, it was about 2 years, but the tail is kind of higher than children. So 2, 3, 4, 5, no one really said over 6. So in that range, 2 to 5 years is how neurologists said that they practice deprescribing anti-seizure medications. The question that I'm actively investigating is why 2 years? There's nothing magical about 2 years. There's no firm line in the sand before versus after where there's this enormous jump or discontinuity in your seizure risk. Risk is continuous and it's a gradual phenomenon that changes over time. But the other thing that I'll point out is that, at least from my experience with patients, it's true that longer seizure freedom duration is an argument for deprescribing due to lower risk, but many other patients will say it's an argument against deprescribing. I've done so well this far, don't rock the boat. It's a marker of success and don't mess with success. So I just find it funny that guidelines express this in terms of at least 2 years of seizure freedom to be an argument for, where it depends on who you ask and how seizure-free duration is interpreted. Which brings us up to the most updated guidelines, which just came out last year in the Journal of Neurology, which is one of the largest neurology journals. So anti-seizure medication withdrawal in seizure-free patients. And basically they dispensed with most firm recommendations. The guidelines provide very few guidelines, I'm sorry to say, and it's no fault of the authors. It's just a matter of the evidence I think that exists. They really don't say 2 years. They really say you should talk about the uncertainty and counsel the patient with some risks and benefits. So what should I do? I've probably confused you and have said too much already. You can say at least 2 years of seizure freedom, and that would be mainstream, even if it's somewhat arbitrary and poorly individualized, and some people really don't follow it. There's other data that I'm not showing to you that there may be an implementation gap in terms of what the guidelines say and what people respond to a hypothetical survey compared to what people actually do in practice, which are two different things. And the 2 year seizure-free duration is kind of ignored by the most recent guidelines that just relegate the how long to a question mark somewhat. I can tell you that tapering anti-seizure medications for epilepsy before 2 years of seizure freedom would be pretty unusual, unless there are certain particular factors. I see patients who have had anterior temporal lobectomy for refractory epilepsy, supposedly curative epilepsy surgery. So that's a different ballgame. Children with benign syndromes like absence epilepsy and other ones is a different ballgame. But these are some just broad rules of thumb. Now, some of you work in post-acute settings, and you might also imagine that if someone has just been hospitalized for something serious and had just been stabilized, the immediate post-acute setting is probably not the right time in terms of pulling away someone's seizure medicines unless there's a really good reason. They were toxic, the toxicity was directly attributable to the seizure medicine, maybe you've checked levels and you've proven that to be true. Maybe you think that central nervous system polypharmacy is contributing to the patient's delirium and that's complicating things. So maybe there can be some settings in which it might be considered. I suppose the flip side is that as an epileptologist, I read EEGs for a living, so I'm on the lookout for non-convulsive seizures that can affect someone's cognition. The point being, though, that perhaps the immediate post-acute period is probably not the right time unless there's a really strong indication for deprescribing, or perhaps if it's used for something else and there's a, other than seizures, and, it seems like a safer ballgame. So there's some groups that I can tell you are probably rarely deprescribed in practice. People get pretty nervous about older patients. I think there are some good arguments that maybe older patients are the prime target for deprescribing. Older patients have declining hepatorenal function. There are differences in terms of volume of distribution, brain receptor affinity to anti-seizure medication and neurotransmitters. There are all kinds of physiologic changes that older adults might be increasingly prone to the consequences of the central nervous system polypharmacy in the setting of more interacting drugs and more comorbidities. Furthermore, there's some data that older adults may have less convulsive epilepsy and, quote, easier to treat requiring lower doses, so maybe lower benefit, higher risk. However, there's just not a lot of data. Of course, you don't want your older patient with osteoporosis to fall and have a hip fracture as a result of a convulsion. Maybe they're on a blood thinner. There are all kinds of reasons why people are nervous about deprescribing in older adults. Structural etiologies, gliomas, strokes, arterial venous malformations, traumatic brain injuries. I see people with structural etiologies, and doctors are oftentimes nervous about deprescribing, and people aware there's a clear brain MRI abnormality. The absolute risk increase probably is not quite as large as people think if you take into account multivariable risk prediction. I have these 10 variables, one of which is the brain MRI is abnormal. So it makes a difference, perhaps not a huge difference, but people get nervous. And then if you've done an EEG, then epileptiform abnormalities on an EEG also is another thing that can increase someone's risk of having seizures. So there's a lot to think about, which brings us into shared decision-making, which is really what the ballgame is about. And I break this into a couple processes. So I'll step you through how I think about shared decision-making in this setting. So first, what kind of person are you? Are you a maximizer or a minimizer? This is actually the product of some rigorous research that the people have done at my institution about decision-making. And it's just under uncertainty, are you the kind of person that wants to take action right away, or are you the person that may want to wait and see? And depending on how someone falls, that directly informs how they view their medications and what they want out of their medical care. Secondarily is not just what kind of person are you, but how do you make decisions? There are different models of physician counseling. There's paternalism, which is, you're the doc, okay, and the guidelines say over 2 years, and so that's what I'm going to do. All the way up to autonomy. The patient is truly the ultimate decider. And this is all blurred together because there's an asymmetry in knowledge between the doctor and the patient, and you must decide how much information to give the patient and how much they want a say, as opposed to saying you're the doctor. So it guides the conversation. There's some general arguments for deprescribing in epilepsy. So a couple bullet points across the 2 randomized controlled trials that have been done enrolling adults that are seizure-free with epilepsy, deprescribing anti-seizure medicines. No one went into status. No one died from deprescribing, although I'll always counsel patients in my clinic about SUDEP, which is sudden unexpected death in epilepsy, which is the thing that keeps epileptologists up at night. But fortunately, this is a very low risk population. Some other general arguments for deprescribing in epilepsy is that, well, if you take someone's seizure medications off or down and they have a seizure, the decision is easy. You restart medications. It's unlikely to be an irreversible decision. You can just restart the medication. Evidence does not support that you've worsened their prognosis. We generally don't see anti-epileptics, anti-seizure medications as brain modifying or disease modifying. When it washes out, the effect wears away, and you can reintroduce the drug. If you have withdrawn someone's seizure medications and driving is important to them, in Michigan, we have a 6-month driving restriction. If someone has a seizure, it differs by state, wherever you live, possibly may not be 6 months. But if it's done in this, if you have a seizure in the setting of a supervised medically supervised medication wean, then you might not have to wait the full period. And if you have a seizure, despite after deprescribing, you and the patient may no longer be left, quote, wondering, is the medication helping and hurting? There are gray areas where I'm not sure if your moodiness or your sleep problems or your word finding difficulties or other things are caused by your medicine. There's an experiment that we can do to find out. The patient says, I've been on this so long, I'm not sure if it's helping. There's an experiment we can do to find out. So these are just general arguments that one can introduce to a patient to see what they think. They're individualized arguments for deprescribing in epilepsy. And here's a set of dice because everything we do in medicine is about chance and probability. And I'll say individualized arguments for deprescribing, but you can just turn on each of these ones inside, each of these points inside out and say these could also be individualized arguments against deprescribing. So one is the diagnosis firm. Sometimes people come with quote, seizure disorder. I would never use the word seizure disorder as an epileptologist. I would always say, is it a provoked seizure or is it epilepsy? But seizure diagnosis may not always be a seizure diagnosis. There are convulsive syncope, there's psychogenic non-epileptic seizures, there's migraines, there's TIA, there are all kinds of things that can mimic. So you're not always so certain. If you are certain, then perhaps that's an argument against, but if you are not certain, maybe it's an argument for. Arguments for could be if the patient has markers of being a low risk patient. So maybe their seizures were provoked, which is a better, more favorable prognostic sign, as opposed to if a patient had seizures just out of the blue without some clear self-limited provoking factor. Maybe there's MRI's clean. Maybe they've had a small number of seizures. Maybe it's been a really long time since their last seizure. Maybe they only needed the smallest possible dose of a seizure medicine to control them. These are all markers of a low-risk patient that maybe would be arguments for considering deprescribing. And then there's the chance of a seizure, but there's also the consequences of a seizure if it did happen. So patients can have convulsive seizures. They can also have non-convulsive seizures. So if someone has big shaking long seizures landed in them in the ICU, it's a very different story than if a patient had small seizures without impaired awareness, auras, focal seizures. So lesser consequences of a seizure, maybe they don't need to drive. So the consequences of having a seizure may not be as great to them. Maybe there are other reasons for a patient to be on a seizure medicine. If not, perhaps that's another argument for. Maybe they think there are a lot of downsides to the medications. They say, I've really tried all these medications. They've all given me side effects. I want to see if I can cut back. Some seizure medicines are costly. Some have interactions. Some patients say, I just don't want to take medications if I don't have to. So there are all these potential individualized arguments for, flip them inside out and say, or against deprescribing in epilepsy. I'll try to tie this together with a couple examples. How might a conversation go? So this is an example of maybe you should withdraw. Well, Mr. Smith, I apologize for reading this, but I think this is perhaps the best way to get the point across. You've only had a small number of possible seizures. They were a long time ago. They weren't convulsions. Maybe they were in the setting when you stayed up late or you were sick, i.e. provoked. You've always wanted to see if you could get off your medicines because of uncertainty about whether they're causing side effects or even if they're helping at all. You've only never needed a low dose of a seizure medication and you don't have another good reason to be on it. So I'm hearing it wouldn't be so bad if you went with a couple months without driving, because I usually restrict driving for a couple months after taking a seizure medicine away if the person has epilepsy. And you've got a good set of eyes on you that can monitor you. And I know you're going to have good follow-up with your doctors. So I'm fine with seeing if you can come off, and we can resume your medication if you have another one. That encapsulates a lot of the elements of shared decision-making and individualized decision-making that sometimes I go through with patients. Here's the flip side of that. Well, Mr. Smith, you've had a lot of seizures. I'm concerned because most of them have been convulsive. None have had clear provoking factors. You really have no problem with your medication. You don't think it's been causing you any side effects or much inconvenience because you take medications at the same time anyways. And your seizure medicine shouldn't really interact with anything else that you're on, and shouldn't have long-term consequences on your kidney or your liver. So it sounds like driving restrictions would be a big deal for you. You need to drive yourself or your family around to take care of your family. So I would suggest staying the course, and we can always reevaluate. So these basically just take that last slide about things that would argue for or against and just directly contrast. These are somewhat the extremes, but kind of the extreme situations where perhaps it's most clear. There are many other considerations that are relevant. So should you get an EEG before you ever consider stopping seizure medicines? And I cannot answer that yes or no in the matter of a minute. Many neurologists will say yes all the time. I would not say yes all the time. EEG is just one tool that can risk stratify your patient. You know, maybe their risk of having another seizure was 30% before you knew the EEG result, but now it's 45%, given that you know there's an epileptiform EEG abnormality. It's a tool for risk stratification that I get sometimes. Some doctors will get all the time. Should you get levels? Well, if you're concerned that your patient is toxic on your anti-seizure medicine, many of our medications, you can get levels. If you want to answer the question, should I try to reduce this person's dose some? Or if they're on the really low side, do they not have enough seizure medications because we just decided that they should continue? It's just another extension of your history in your exam. So there are times when the level could be useful. And I talk to my patients about seizure detection devices. You know, some of the heartburn involves what if the patient has an unwitnessed seizure, an unwitnessed convulsion, and then something serious happens. Well, there are FDA-approved seizure detection devices that I use in different settings. Sometimes when the person has refractory epilepsy, because then it can get attention to the patient very quickly. In theory, I suppose, if you're taking someone's seizure medicine away and you need another set of automatic artificial intelligent eyes on them, then I suppose that's an option. There are always alternatives to deprescribing. So one is just reducing. Maybe they've been on 3 medications and you say, I wonder if we could get away with 2, or 2, and I wonder if we could get away with 1, or reducing to the lowest effective dose without going all the way and stopping. Of course, the decision is not just reducing or stopping, you can also switch. If you have that shared decision conversation and you think they should be on one, but this is not the right one, you switch them to a better tolerated one or a medication with fewer drug interactions. You switch them from phenytoin to levetiracetam or lamotrigine or lacosamide. There are many options that are newer that may have fewer interactions compared to something that we've been on a long time. And continuing, obviously, risk benefits alternatives. So I just have a few slides. I'm almost at the end here. Developing a tapering plan. My strategy is, let's say you've decided to try to come off of a medication. I'll take away little by little. Typically, there's no urgency, and typically it's over a few months. So say someone's on 500 milligrams twice a day of levetiracetam. That's perhaps the lowest dose. You could just stop it right then and there. If someone's on a higher dose, maybe week 1, this, week 3, this, week 5, this, week 7, this. So every 1 to maybe 3 weeks, you make a little change. Day, night, sometimes it depends on some patients' seizures have historically been nocturnal predominant. That's the time when the brain is most synchronized. So maybe you'll take away the morning dose first and maybe the evening dose in terms of your slow, cautious tapering plan over a few months. There has been some data about speed of tapering when developing a tapering plan. And there's one randomized controlled trial that came out recently, and there's a Cochrane review. Basically, there has been no clear difference in terms of quote fast versus quote slow tapering, or at least there's not great evidence either way. So over a few months. Who should be in charge? Maybe this is something that you're wondering. Should I possibly be the one to do this? Well, the non-specialist it could be reasonable. I mean, you are there managing the patient's chronic complex conditions in a post-acute care setting or a long-term care setting. You could consider deprescribing if you deem that you have a patient that's low risk to stopping and high benefit from stopping, and they're on this medical minimizer spectrum. So everything lines up, the patient's preferences, the patient's biological risk, all point in the right direction. It seems reasonable to refer if you're not comfortable doing that. You really want a pair of specialty eyes on them. I would honestly never fault you for referring a patient to a neurologist or an epileptologist if you have access to specialty care, at least as an initial consultation, either for diagnostic clarification or some input regarding treatment recommendations. The real quality metric that we have in epilepsy care, outpatient epilepsy care, is that if someone has refractory epilepsy on the other end of the spectrum, you should refer them as quickly as possible to a specialty center that can take people through refractory epilepsy care and consider surgical evaluation. But that's the only quality metric in terms of referral. So maybe some of these points are useful. So I believe this is my final slide. I'll end with a few tips, and then I'll circle back and check the chat and see what questions have accumulated. So tip number one, and I bold and underline this, is just why the heck are they taking it? Not all anti-seizure medications are taken for seizures, and your heartburn will be less if they take it for restless legs, or if they take it for tremor, or if they take it for fibromyalgia, compared with if they are truly taking it for convulsive epilepsy. It changes the shared decision-making conversation. Number two is don't take the chart for granted. People with a quote seizure disorder diagnosis, with any diagnosis, it's really best practices to confirm, get that evidence. Why do they have that? What did they have an EEG that was abnormal? Where was it done? What's the history? How many have they had? Sometimes I get consults from the emergency room, and the emergency room says the patient had a seizure, and I ask, well, what happened? And the conversation is they had a seizure. And I'm like, I need more information than that so that I can truly understand the diagnosis and whether the patient has an indication for the treatment that I can provide to them, given considerable diagnostic ambiguity in terms of seizure diagnosis. The decisions may not be as make or break as you might think. In the trials, nobody died. That's not to say that it's not possible that someone could have a serious consequence or even die from withdrawing seizure medications. On the flip side, we have studies, stronger studies, that show poor adherence to anti-seizure medications and people who have a reason to be on them have increased hospital use, even mortality potentially. But in the studies, it's the low risk population. You just restart the medication if they have another seizure. That is the most likely outcome after this careful risk and benefit conversations. Decisions must also be individualized. Over 2 years seizure-free is what neurology residents have been taught a long time. But in my practice, I take that perhaps as a starting point, but then I tailor that to the patient as much as possible. Doctors may be particularly reluctant in certain populations, older people, structural abnormalities, abnormal EEGs, et cetera. And often I should conclude by saying it's often perfectly reasonable to continue. Oftentimes in these situations, if the patient's doing well from a seizure standpoint, you're dealing with lots of other medical issues. So there's often no urgency to stop unless you're really concerned that the patient is toxic and having care-limiting side effects or drug interactions from a given medication, in which case it may be the time to about face or change course. In the post-acute setting, you're unlikely to potentially destabilize someone unless there's a real reason to question that seizure medicine or question the indication that it's not really seizures. And finally, I would never fault you for referring, although with the caveat that the number of patients are far greater than the number of neurologists. So refer if you have access to such specialty care. So this talk has been brought to you by many references, only a few of which are mine. And I hope to have more references by myself in the future that I can share with you in future talks. So that's
wow. Sam, this is phenomenal session. Really, I mean, I don't think I've gotten, no offense to previous speakers, but I don't think I've gotten that many amazing pearls on a topic which has been tough for me personally. And I think you may have cured my my heartburn, so I'm going to stop using that PPI now. So that's awesome. So I can deprescribe myself. But I think some of the key things which you gave, I just want to emphasize, which probably will help my heartburn and pedi people. I just want to kind of repeat those, is that nobody died in these RCTs, guys. Come on. I mean, if you truly believe as the post-acute expert, physician, practitioner, pharmacist, or whatever interprofessional team member you are, stopping is not the wrong direction in any way, because you're not going to harm the patient, particularly if there's good reasons that there's going to be side effects probably from this medicine they're using. So to me, that was the best possible tip, is that go ahead, give it a try. And the other thing I'm just is like, get a neurologist involved, right? I mean, in that chart, go dig up the name of the neurologist, and if you can find out from the family member, just call them, and you can see how friendly neurologists can be, as you have seen how friendly Sam is. So call them and just have an interprofessional conversation, and that will help you further. So I honestly learned a lot. I just have a quick question for one, if you can answer it in like 10 seconds, Sam, because we want to go to quick questions. There's a few there. Sam, what is the safest anti-seizure medicine? If there's 3 anti-seizure medicines somebody's taking, what is the safest one in older people that we probably could continue using?
Well, the 10-second answer is that there has been one meta-analysis, and there is one recent guidelines about newer anti-seizure medications that suggested that lamotrigine was among the top choices for older adults. The meta-analysis suggested that lamotrigine was, I'm not sure if safer is exactly the word, but better tolerated than carbamazepine. So clearly there are 30 medications. Studies haven't compared every single one head-to-head. Studies comparing head-to-head, there have been a few in older people, but I suppose lamotrigine, it has fewer drug interactions than some of the older medications, but levetiracetam is often a second line one that we use. Lacosamide, I used to give a lot of flack to because it was brand only for a long time. It's extremely expensive, but it's recently gone generic. So it's all a matter. I apologize, this is more than 10 seconds. But with the caveat though, in terms of safety, there is a black box warning now from the FDA about lamotrigine and cardiac arrhythmias in people who have cardiovascular disease. It was found that in a dish, there were some potentially serious arrhythmias. The applicability to actual patients is less clear, but there is a warning. So there is a small list, and levetiracetam, lamotrigine, oxcarbazepine. There are a few others on my short list that I typically use with patients young or old.
Great.
Great. Michael, please go ahead.
Yes, thank you. So we have about 7 minutes or so left. There are 2 questions here that may be related. One, I'm seeing an increase in starting levetiracetam in someone who recently had a stroke, but did not have a seizure. Could you address when it's appropriate to request the medication to be discontinued if seizure free? And also, when do you stop seizure medication started for prophylaxis after hemorrhagic CVA?
So in terms of prophylactic seizure medications, after ischemic stroke, the numbers are something like 6% of people post-stroke will eventually have seizures. So it's lower than I would have thought. In the overall population, 1, 2, 3, there's this number on the Epilepsy Foundation, 1 in 24, I think is their number, will have epilepsy in their, or seizure, epilepsy in their lifetime. 1 in 9 might have a seizure. Stroke is a risk factor, but the cumulative incidence of having a seizure after a stroke of say 6% is way below the threshold that neurologists typically use to actually start and persist on a seizure medicine, which is 60%. So it's an order of magnitude smaller risk than usually we require before starting a seizure medicine. So if a patient hasn't had a seizure, I would very rarely actually start and continue them on a seizure medication. Now, our neurosurgeons, I think neurosurgeons are more aggressive, and it's more routine for them to start a patient on a seizure medicine after a hemorrhage compared with perhaps neurologists. And honestly, if you put a patient on levetiracetam, there's not a lot of harm. I mean, it's a medicine that can have mood side effects. But if someone has a acute symptomatic seizure, for example, say they did have a seizure right away, the prognosis for having another seizure is better than if they have a remote symptomatic seizure. Like they had that hemorrhage 10 years ago and they had a seizure today. That's worse than if they had a hemorrhage a day ago and they had a seizure today, because presumably things were still on fire and things may cool down.
But if they have not had seizures, these could be candidates for deprescribing.
Definitely, yeah, definitely.
Excellent. Next question. And these may be related, does the incidence of seizures increase with degenerative dementia progression? And that was followed up by, that's my question as well. We know we see an incidence around 15% for Alzheimer patients to eventually have at least one seizure. So what would deprescribing look like for these patients? Granted, typically late stage, but we know that staff don't typically handle seizures well, high risk for sending out and benzos, et cetera.
Yeah, so if you have a patient that's older, has brain atrophy, has Alzheimer's disease, and you really think has epilepsy, then it's in that box where I said doctors are pretty reluctant to stop seizure medicines often. There is a structural brain abnormality. In one of my references, I show some data about deprescribing in patients with gliomas, which is, as bad of a structural abnormality as you can get, irritating the cortex. And they had 30% risk of having a post-withdrawal seizure. Now, maybe that's a selected cohort. It's perhaps lower risk than you thought it would be, but nonetheless, I think I would probably, there is a time and a place if you think that the medicine is causing more harm than good, but a lot of people would be uncomfortable with deprescribing. It is truly an active area that I wish to learn more about in my future research.
Excellent.
There's probably a bidirectional relationship. Well, there is a bidirectional relationship between cognitive impairment and seizures.
Thank you. A question, if on 3 seizure meds, where do you start?
Oh, which one?
Yeah.
Okay.
You can get creative since we didn't tell you which ones or anything about the patient.
Right. Well, look, it's not a read my mind question because I understand what you're asking. And I try to prioritize which one do you think helped you the most? Which one do you think has caused you the most problems? Is there a medicine that is most interacting with your other drugs? Is there a medication that requires the most monitoring and blood work? So, if there's a patient's on phenobarbital, maybe that's one they've been on a really long time that has implications for bone health and requires blood checks as opposed to levetiracetam. Whereas if they say, ever since I've been on levetiracetam, I've been totally moody, I don't like who I am, then that sometimes narrows down the list.
Thank you, because then we'll start an antipsychotic or something. Sorry. Question, levetiracetam levels, yes, no?
Neither yes nor no. It depends. So it is a medication that you can check levels on. There's no free versus total levetiracetam, so it's just a levetiracetam level. So the reason that I might check a level in someone who's doing well, sometimes I might check a level in someone who's doing well just as a baseline. At this moment, you've been seizure-free a long time. Let's see where you're at, see if you're in the therapeutic range. But it's merely a tool because, well, say a year later you come to the emergency room with seizures, I want to know how is your level at that moment compared to the level when you were doing well. Because if it was good on year 1 but bad in year 2, then that might suggest that your relapse was because of inadequate medication or inadequate adherence, as opposed to if your level was exactly the same or higher, then maybe it makes you more likely to look for other things. So that's point 1. Point 2 is to look for toxicity, potentially. Although levels, as I said, are just an extension of your history and exam. I rarely check levels just to monitor people. Like I'm just about never going to check phenytoin levels every 6 months just for the heck of it. I just don't see the point of that. I check levels if I want to know how is someone stable, or if there's a free level and I want to know the person's nutritional status is out of whack and they're on interacting drugs and by the way, they're on Coumadin and I really want to keep a tab. So those are some of the situations. And I apologize. It's not a yes or a no answer, but yes, sometimes.
Thank you for helping us work through that. And last question, and briefly, in our last minute, how does a person with epilepsy or convulsions not show, how often does a person with epilepsy or convulsions not show significant findings on EEG?
Yeah, it's a good question. Well, so I work in the epilepsy monitoring unit, and you can have focal motor seizures, like just twitching in one part of the body with preserved awareness. And you can see about a quarter of those show up on the scalp. You can imagine, so that's probably the lowest. And that's like during a seizure. And it's because the brain is so folded and convoluted, and some seizures are from deep in the brain, and there's spinal fluid and meninges and skull and everything in the way. Perhaps some of the classic numbers are in a 30-minute EEG, maybe about a third of people will show epileptiform abnormalities. You do another EEG on another day, or you monitor for 24 hours, maybe you get up to 67, 80%.
Thank you. Those are our questions.
I think we are right at time. Wow, this is a phenomenal session, and I just can't wait to share with many medical directors and practitioners I work with, and I'm sure many of you are representatives of large organizations. Sam, your impact is going to be felt across the post-acute setting. I can assure you that. We do hope that you will be back and with some amazing conversation. So right on target, your session was. It was very impactful, great best practices. Thank you everyone who joined today, and thank you to especially to the AMDA staff who was phenomenal in getting this all together. We hope that everybody's enjoying this series on Drive to Deprescribe. Please stay tuned for our next session in the next 4 weeks, which is going to be more towards kind of an office session around best practices. And in 2 months, we'll be back with another topic. Thank you so much for joining. And with that, I'm just going to end up with AMDA staff. Is there anything else I'm missing at this point before we adjourn?
I don't think so. We'll send an email out next week with the recording and the slides.
All right. Thank you, everyone. Have a great evening.
Thank you.
Thank you so much. Thank you.
Thank you.
Thank you.